So good afternoon, everyone. I'm Alex Mavroeidi, and today I was very kindly asked to come and speak to you about nutrition and bone health. I believe some of you have already been to kind of a workshop, a cooking workshop earlier on, so maybe you can kind of get me some ideas about good nutrition advice as well. Just in case you wondering who I am, so I'm a reader and I'm the head of department for occupational therapy and human nutrition and dietetics at Glasgow Caledonian University. I worked in the area of osteoporosis for over 20 years now. That's depressing, so let's move on from that. Actually, it was interesting to hear the lady just before me. She talked about David Reed, who helped her with a diagnosis and giving her kind of a drug treatment. So he was my PhD supervisor, so it was very interesting to hear his name being mentioned. So I'm here to speak to you about nutrition. This morning, you already heard about another modifiable risk factor for osteoporosis from my colleague, Dawn Skelton. So both nutrition and physical activity are risk factors of osteoporosis that you can do something about. There are, of course, other risk factors that there's not much you can do about. You can't choose your mom and dad, therefore you cannot choose your genetic predisposition to get osteoporosis, and you cannot turn back time. Some of us are getting into those menopausal years, so the estrogen withdrawal is a real fight. It's going to happen, so there's nothing I can do about that. But there is definitely something we can do about what we eat and what we do, what physical activity we do. I'll speak to you today about nutrition. Okay, so apologies, this is a little bit too small, so apologies, it looks smaller on your screen. So the SIGN guidelines, so you'll hear me talking about the SIGN guidelines quite a lot. So they were first developed in 2015 from a large group, quite a few people were involved in that. Alison Black, who you've heard earlier on, was also involved in the development of the original SIGN guidelines, along with Stuart Ralston and lots of other people from Aberdeen. But they have been updated in 2021, and I'll show you some kind of information from the updated guidelines. What it meant is that lots of people got together and looked at all the evidence that is related to osteoporosis and the prevention of fragility fractures. And they looked at all the evidence as far as pharmacological interventions are concerned, as far as nutritional interventions are concerned, as far as exercise is concerned, and kind of tried to put it all together and kind of make sense of it, okay? So within that, those guidelines, when we look at the area where it looks at diet, it does highlight one of the kind of the recommendations from the SIGN committee was that a balanced diet is recommended for bone health. But when you look really closely at the evidence, there's no evidence that a specific diet could reduce your fracture risk. Of course, if you make big changes to your diet, which may result in an imbalance of certain groups and nutrients that could affect your overall intake and also could be detrimental to your general health, bone health included. So I don't know what a healthy balanced diet is to you, but this is what it should be. So this is one of the schematics I'm sure you've seen around, hospitals, and it's one that we often use kind of as dietitians. So this is the Eat Well guide or the Eat Well plate that shows you that over the duration of a day, this is what all of the foods that you should be eating should look like and at what proportions. So it tells you that you need to have a healthy amount of fruit and vegetables, that you need to have a healthy amount of complex carbohydrates within your diet, and there is also space. Oh, can I use the pointer? Sure. Yes. This way? Yep. Ah, there you go. Fabulous, sorry. That there's obviously kind of an importance for good health and in a balanced diet of protein sources and obviously calcium sources as well. Things that people enjoy and eating a lot in the Western diets are out completely of the plate, effectively telling you that you shouldn't be having any of those, or at least they don't contribute to a good, healthy diet. So that's what, when the SIGN guidelines talk about a good, healthy diet, that's what it is implied, that we're following a pattern that looks a little bit like that. Okay, let's move to the next one. Right. So, for if those of you who are interested to know what does that mean for the individual, for as far as total energy and protein intake it is, I've put kind of the values there. I do apologize. The writing was so much bigger on my computer than it is on your screen, so I do apologize about that. So I've put them there for your perusal effectively, and have a good look at them. More related to energy intake or protein intake per kilogram body weight per day. That's because we're not all the same. We're not all the same size. Therefore, we're not all required exactly the same amount of energy and or protein in our diets. Does that make sense what I'm saying? Yes. Okay, good. Okay. So the SIGN guidelines don't really talk about protein, so I am going a little bit off-road here about talking to you about protein, but I'm doing this because when I give a lot of talks to support groups, osteoporosis support groups, and kind of lots of physiotherapists who are dealing with kind of osteoporosis patients, etc., and trainers, and they always ask about protein in the diet and what effect protein intake might have on bones and on muscle, if I'm being honest. So we do know that diets who are moderate in protein intake, so about 1 to 1.5 grams of per kilogram body weight per day, are associated with normal calcium metabolism, and they actually don't alter the bone metabolism. And we know that if you are below that, quite below that, so if you're on a low protein intake, below the 0.8 grams of protein per kilogram body weight, then that can have a negative effect on your skeletal health, if you want. So it is associated with intestinal calcium with a reduction in intestinal calcium absorption, and also with levels of your parathyroid hormone going up, which actually has an effect of causing a release of calcium from your bone, so breaking down bone as a consequence of changes in your hormone, your PTH hormone, if that makes sense. So normal protein intakes are quite important for good bone metabolism, is what I'm trying to say. So where do we get protein from in foods? So there are a couple of examples here where we can get protein from and how much protein you would get. So you will see that there is animal sources of protein and plant sources of protein. Generally speaking, the animal source of proteins have got a higher proportion of high quality protein that's got amino acids, a mixture of amino acids that are high. So eggs will be the best kind of type of protein if you want it. And then as you get into the plant kind of sources of protein, that quality of the protein kind of reduces. What I'm trying to say, I always get asked, so if protein is important for bone and it's important for muscles, should I be, what should I be doing about this? Should I be taking protein supplements? And the answer is absolutely not, because we can achieve a very normal and quite often quite high protein intake by eating just normal food. So here's an example of a meal sample, and I always put that to actually prove to people that it is very, very doable with just by eating food. So just simple food, nothing too exciting there, just by having some portions of protein in every single one of your big meals will be able to get you to that level of actually the higher level of the range that I was advocating earlier on of 1.5 grams of protein per kilogram body weight for your average kind of 70 kilogram person. My calculations there. Okay. So protein obviously is important for muscles as well. So this has been looked up. There was a big Cochrane review that looked at over 10,000 patients and looked at protein and energy supplements to see whether there was a beneficial effect of those on muscles. Some was observed in terms of weight gain, but there was, overall speaking, no beneficial effect on mortality, on total mortality, and actually very, very few trials showed any beneficial effect on functional benefits for older adults. I should say that the majority of the studies that are done on protein and muscles are on younger adults, so there isn't that much information on older adults, and especially on older adults with osteoporosis. There are some studies that they don't just look at protein in general, but they look at specific amino acids that might be related with muscle anabolism. So, you know, I've listed those below. But again, there's been some benefit to improve muscle mass and function. But again, the problem is the majority of those studies are done on young, fit and healthy males rather than older adults. Well, probably what I'm hoping that you remember out of this presentation is that actually by eating a normal varied diet, you are actually easily meeting your protein requirements. So this is a big survey that we do in the UK on regular kind of intervals. So the NDNS survey, so it's got participants from all over the UK. And I've just put down a few data from some of those surveys showing you that whether you are a slightly younger adult or whether you are an older adult, you are very easily meeting your 15% of total energy intake coming from protein. So in the UK, as a population, as an average population, we are meeting our protein requirements. Does that make sense? Yet I'm often asked, that's one of the most common questions that I get asked by physios, for example, or even by kind of osteoporosis patients, should I be doing something about my protein intake? And my answer is, if you're eating a healthy varied diet, you don't really need to do anything about it because you would be meeting your requirements regardless. Okay? So I'll stop about protein now, and then I'll come and speak about calcium. I mean, obviously, calcium is one of the most well-researched, if you want, nutrients in relation to osteoporosis for obvious reasons. Calcium is very important for the formation of bones. It's the main mineral that bones have, and it's related with the mineralization of bone. So there has always been interest in the scientific committee what is the association between dietary calcium, how much calcium I have in the diet, and how good or bad my bones will be. So in general terms, so this was looked by the SIGN both in 2015 and 2021. And I will say that, you know, as far as calcium is concerned, obviously we want to be meeting our population requirements, and I'll go into that into my next slide. But generally speaking, any meta-analysis that have been done on supplementation studies or any prospective studies doesn't show that the more calcium you have in the diet, the better your bones. Okay, so more doesn't necessarily means better. You do, however, need to meet your requirements. Okay, so this is what the UK recommended nutrient intake is for calcium. So I've put it for all of the age groups effectively, but I guess the ones that are more relevant to us here are adults, everyone above the age of 19 years. So that's the recommendation. For UK adults, and there are certain circumstances during adulthood that you might require more calcium. We heard about one earlier on, what happens during pregnancy and why the pregnant women might require, and breastfeeding women, I should say, might require more calcium. So that is recognized here. So you would need to add those 550 to the 700 if you were during pregnancy and lactation. There is also quite a lot of data to show that if you have osteoporosis and you are taking a bisphosphonate, for example, all of those studies that have been done with bisphosphonates would have been, patients would have been given a supplement of calcium and vitamin D. as well. So you don't just take the bisphosphonate, but most of those studies would have had a calcium and vitamin D supplement as well. So there is the notion that if you're in osteoporosis medication, it might be beneficial to have a slightly higher calcium intake, which probably is met by a supplement rather than by the diet. Does that make sense? Yeah. Okay. So if you were to get calcium from the diet, where would it come? Well, obviously dairy and dairy products will be is your go-to place for get calcium. But of course, there are loads of plant-based sources of calcium as well. It's just that I'll show you a couple of slides later on to see the content of dairy vs plant-based and why we need to pay a little bit more attention there. So green leafy vegetables are known to be high in calcium, but do be wary that some of them have got this other organic compound called oxalate. So spinach is one of them, for example, that binds that calcium. So although a plate of a lovely spinach salad might have a lot of calcium, when you eat it, that doesn't mean that all the calcium that is in your spinach leaves will actually be digested and absorbed by the body because it's bound on oxalates. Yeah. See. So again, it's the writing is a little bit small. You don't have to read it, and you're going to have the slides afterwards, so you can have a little bit more look there. So these are foods mainly in here. You will see plant-based, quite a few plant-based ones, that they can only give you 50 milligrams of calcium per average portion. And then you will see that as I change the slides, the one portion of these other foods that I'm showing you here and here will give you more calcium. So what you need to do if there's any vegetarians or vegans amongst you, I'm not saying that you cannot meet your calcium requirements, quite the opposite. You just need to probably have bigger portions of plant-based calcium sources than you would. For example, you would only need to have a pint of milk and you would meet your calcium recommendations if you were able to have animal sources. Yeah. Okay. Now, you might say to me, do I need calcium, Alex? Well, the answer is, I don't know. It's very individualized. But you can quickly check is the answer. So there is a little quick calcium calculator. On the next slide, I've given you the actual website where you can go. So just by calculating within a week how much of these commonly consumed calcium-rich foods you have, you can actually have an estimation of how much, whether your calcium intake, your average calcium intake is high, low, and how much. So I did that for myself in the train today, and I'm ashamed to say that I don't meet the calcium recommendations by what I ate last week, basically. So you will see there. So I've just put down all of my kind of portions, or at least what I thought I ate last week, and must do something about that. Note to self. Okay, so when you go home, I think that's quite an interesting one to do. The GPs quite often use this little kind of calculation, especially if they're assessing, if you're there and they're assessing your risk for osteoporosis, they can easily put in very, very few, as you can see from here, foods from your weekly kind of from what you eat weekly, and actually find out whether you're meeting the recommendations or not. So remember, we are aiming for 700 there. Okay. Okay. And I will move on from calcium to vitamin D. So vitamin D is the area that I kind of have done a fair amount of research in. Vitamin D, again, is an obvious nutrient to look at in relation to osteoporosis and bone health in general. Why? Because vitamin D is related with calcium homeostasis. So therefore, they're very much interlinked. So these are the kind of things that I would like us to look topic today. So whether there is an optimum amount of vitamin D per day for an osteoporosis sufferer, what foods are high in vitamin D, and is it better to use supplements, or is it better to get vitamin D from foods themselves? I've put those questions there because that's the type of questions that I get asked. So I also help with the Royal Osteoporosis Society, and some of those questions are from the helpline. These are the stuff that the nurses who pick up the phone and speak to osteoporosis sufferers, these are the things that they're kind of interested in. Right. Okay. So this is quite an old study, but I really like it. I really like it because a picture paints, it says more than words, all right? So this is a work by Elina Hyponen, fairly old now. When was it? 2007, very old. But it shows you, so what they did is that they took blood samples from lots of people from all over the UK at different times during the year. And what they did is that they look at what proportion of the population had 25-hydroxyvitamin D, which is the metabolite of vitamin D in your blood. So how many of those had low, or they were hypo, as Elina identified them? So how many were below 40 nanomoles per liter, okay? So on the graphs that you can see, it identifies the darker the graph, the higher the proportion of the population that is below that 40 threshold there. Does that make sense? So what you can see is that there is definitely a seasonal variation, okay? So you have a higher proportion throughout the UK that they have low levels of vitamin D in the winter and in the spring compared to the summer and the fall. And there is also quite a marked regional variation. Regardless of whether you're looking at winter, spring, summer, or fall, there is definitely a higher proportion of people who have lower levels of vitamin D if you live up north compared to down south. Does that, yeah. So vitamin D, of course, is very much related to sun exposure. We make most of our 25-hydroxyvitamin D by exposing our skin to the sun. Okay, and that's why, for example, you have higher levels of vitamin D during the summer when there is more sunshine around, and during the autumn compared to the winter. In fact, some of the lowest levels of our vitamin D would be during the spring, because we've used up everything that we made during the summer and the autumn. We've used it all up during the winter, and actually we are at our lowest in spring, ready for our next hit of sunshine, if we're lucky, during the summer months. Okay. There's obviously, so the other thing about sunshine and making vitamin D from sunlight exposure is obviously latitude as well. So the higher up we are, so the less likely we are to get kind of the right type of UV wavelength in order to make vitamin D on our skin. Okay, so we here in Scotland are at a disadvantage compared to our southern counterparts, if that makes sense. So these are things that were considered by the, sorry, I'll go back to that. So these were things that were considered by the SIGN guidelines, of course, and I'll tell you what they said later on. After this one, we did an interesting study up in Aberdeen with Helen MacDonald and David Reid, actually, where we looked at the same women longitudinally, because the issue with these type of studies is that there were different people that they looked at different times in different locations. So people might say, well, you're comparing things that you couldn't compare directly. So we took a large group of women and we followed them over 15 months. So every 3 months they came into the osteoporosis unit up in Aberdeen, and we did lots of questionnaires with them. We took blood samples, we took the pictures of the color of their skin, we did lots of things with them, and we followed, and we we therefore had data for over a year of the same people and looking at what their 25-hydroxyvitamin D levels did. Okay, and at the time it was kind of the first study that kind of had done that. And what we noticed is very similar stuff like Elena did. So that there was all of those women were up in Aberdeen, so same latitude, right? Okay, so bear that in mind. But there was a seasonal variation of their 25-hydroxyvitamin D. So there was definitely a very similar pattern as far as the seasons are concerned. Okay, we also compared our ladies with another very similar cohort from down south, from Surrey Uni. Now, Surrey Uni, for those of you who don't know, is kind of down here, kind of around close to London, okay? And there also had a seasonal variation, but overall, the 25-hydroxyvitamin D was much higher throughout the year compared to us, all the women that were in Aberdeen. So that was quite interesting. Other things that were, diet didn't seem to make a lot of difference, so we adjusted for diet. I'll tell you why in a minute. We'll chat about that in a minute. But what did make a difference is cod liver oil consumption. So those women who were taking cod liver oil that has vitamin D in them, they also had the same seasonal variation, but they were above the women who did not take cod liver oil throughout the year. The other thing that made a big difference is going on holiday abroad. I tried to push that message at the time, but no one was listening to me. I wonder why. But yes, so if you had a holiday abroad for more than 2 weeks, then your 25-hydroxyvitamin D was higher than those women who didn't go on holiday at all throughout the year. Yes, it decreased during the winter and the spring, but overall it was higher. Okay. So post our study and a few other studies that there were at the time, there was a lot of kind of pressure on the government to actually review their vitamin D recommendations for the UK. Up until 2016, we were telling people that here in the UK, regardless of where you were in the UK, that don't worry, just going out and about during the summer will make you enough vitamin D to last you for the whole year, right? Okay, so we were telling people that that is enough, and we didn't have a recommended nutrient intake for vitamin D. We didn't tell them that they needed to actually have certain amounts of vitamin D through food or supplements. This all changed when this report by let's go back, by the Scientific Advisory Committee on Nutrition was published in 2016, where they reviewed all the evidence, and they probably agreed with what we already knew, that they suggested that everyone in the UK should, over the age of 1 year, should get 10 micrograms of vitamin D every day. Okay? For health, not just for your bones, but for general health as well. And that was a difference, because it used to be 0, and it came up, the Saccharin changed that to 10 micrograms. Okay. The reason why diet itself probably doesn't make a big difference in your vitamin D intake is because there's very few foods that naturally contain vitamin D. I've listed them here. Now, fortified milk, apologies. I like this picture, but the fortified milk annoys me because we don't have fortified milk in the UK, right? Okay, so this is an American picture. The rest of those stands. So we get vitamin D from very, very few foods, if you want. Yes, the majority comes from the sun. There are a few foods, but if you're not very keen on eating eggs and eating fatty fish, then it's very difficult to make those 10 or 400 international units per day. You see where I'm coming from? Okay, so actually you can have a look at that one, but I put it in a little bit more kind of context here. What kind of types of food could give you 20 micrograms or, a bit less, and you can see that it's slim pickings if you don't like fish. I'm going to be honest. And you have to like fish every day. My kids would not have that. I can tell you that. To be fair, neither would I every day. And there's more here as well, so that you can see. So in the UK, we fortify margarine with vitamin D, but I'm not advocating you go out there and eat loads of margarine either. But generally speaking, diet doesn't make a big difference into your vitamin D intake. Okay, so therefore, this is where you should consider the use of a vitamin D supplement. Okay, so indeed, Saccharin recommended that everyone should make sure that they get 10 micrograms of vitamin D per day from food sources, if you can, and consider whether you need a supplement, especially at the time of the year where your vitamin D stores are depleted, so during autumn and winter months. Okay, and then Public Health England went on to suggest that recommending kind of a supplement, and this is what they suggested. You can see it here. Okay, on the back of that, the 2021 guidelines went on to say from SIGN that in Scotland, dietary vitamin D intakes are insufficient to meet the needs of people with inadequate sunlight exposure, and that supplementation with 400 IUs during the months of October to March should be considered to avoid deficiency. So even if it is a beautiful sunshiny day, I mean, not today, but if it's a beautiful sunshiny day between the months of October and March, we cannot make any vitamin D by sun exposure here in the UK. Why? Because the sunlight is not of the right wavelength. So during October and March, we rely on our stores that we've made the good months when it was nice and sunshiny, right? Okay, so but what SIGN are telling us is that identifying that perhaps we don't get that much sunshine even during the summer in Scotland, that we definitely need to consider taking kind of a supplementation during the winter months. In fact, also SIGN identified a few other people who might be a high vitamin D deficiency. So these would be children under the age of 5. These would be women who are in pregnancy and lactation. These would be people who are cover up for religious reasons, for example. These will be people who have of an Afro-Caribbean or South Asian kind of a background, who have dark skin and therefore require higher levels of, they require more exposure to the sun to make the same amount of vitamin D that I would. So these people who might be at risk of vitamin D deficiency should actually consider whether they should take a supplement throughout the year. These are recommendations. It's up to you whether you decide to do that or not. But that's what the government is recommending just now. Okay, now that's an interesting one. So, so this is from a colleague from the Americas. So he is he's an advocate of vitamin D, and he created this app that you can download on your phone to track your vitamin D. So this is tracking vitamin D from the sun to tell you how much you've made each day, and bearing in mind of the how much sunshine was around that day, and you know how warm it was that day, and by you putting in some information on how much of your skin you exposed to the sun, and tell you whether you're meeting your vitamin D recommendations from that day. So if you want to play around and download the app, feel free to do that. It's a free app, by the way. So yeah. Now, the SIGN guidelines did look at some other nutrients, because you might say to me, come on, Alex, it's not just vitamin D and calcium that is important for bones. And the answer is, of course not. There's other nutrients that are very important for bone. So I've kind of list of all the other stuff that Saccharin looked there, in case you wanted to have a look at that. So vitamin A, so this is the stuff that you kind of get from liver and kind of liver products. You know, Saccharin looked at the evidence, and there is kind of a lot of evidence there to say that we should avoid excess intakes of the preformed retinol, and that, you know, we need to kind of adhere to these kind of recommendations. Recommendations, no more than that per day. They looked at vitamin B's and vitamin K, also associated with bone formation, antioxidants and fatty acids, and you can see that a little bit misaligned here, so I apologize about that, but that denotes to that. So for vitamin K, for example, we know that high dosages are not recommended. They looked at other things as well, phytoestrogens. Have we heard of phytoestrogens before? So, these are plant estrogens that mimic the kind of organic constitution of estrogen, and people advocate them as kind of, not as a natural HRT if you want it. And we would. The evidence is simply not there for these kind of natural kind of estrogens, so they're not recommended to prevent fracture. There is a lot of chat about caffeine-containing foods and beverages and whether they're good or bad for bone and as well. So there is some studies that show that there's an increased risk with high intakes, but we're talking about high intakes. So the recommendation from SAING is that you should restrict your intakes to no more than 4 cups of caffeinated drinks per day, especially if your dietary calcium is low, just because it interferes with the calcium absorption, basically. And that's all I have to say, if I'm being honest. So in summary, I would say that for women who are around the menopause, then this is a time to reevaluate your eating habits and make healthy choices. It's never too late to do something about the modifiable risk factors of osteoporosis, diet being one of them. Then if we have people who are they're older or frailer, then I would say that the Eat Well plate is a good place to start. And remember that you don't have to eat a huge plate of food. You can have much smaller and more frequent portions and sizes throughout the day. Remember to have enough protein in your meals because low levels of protein seem to have seem to be associated with an increased risk of hip fracture. Calcium is important, but not more than what the recommended nutrient intake is. And vitamin D definitely, as per the new saccharine guidelines, to be about 10 micrograms per day. And that's it. Any questions for you? And I've got pretty pictures from GCU. Microphone up. Yeah, just in case. Yes. Yes, as far as I know. Yep. There you go. I can go back.
Okay. Yeah. Thanks. Yeah. Vitamin K. Yeah. So high dosage, not recommended. So I was interested in that. And also, you can get some that are vitamin D and K together. Is that better than just taking vitamin D? And should you therefore not take vitamin D and vitamin K?
So it really depends on how much your dietary intake of vitamin K is. So, and I couldn't kind of give you an advice of that because I wouldn't know by not knowing what you eat, basically. But if you think that your vitamin K is around the recommended nutrient intake, which I have put it there, so the RNI, then I would say nothing above that. And definitely look at the supplement that you're taking. You definitely don't want anything above that. Yeah, so there is good, strong evidence about vitamin D and kind of bone health, so that those at least 10 micrograms per day. So that is a safe bet if you want it as far as supplements are concerned. The vitamin K one, if your dietary intake is 0, then yes, by all means, but I don't know that. Yeah, if that makes sense. Good.
Sorry, what is the harm of taking extra vitamin D? Because the one I'm taking just now is 500 milligram and is slow release. So I take it in the morning and it's supposed to release at the end of the night.
Have you been prescribed that vitamin K or vitamin D? Sorry, is it or do you take it as a because quite often if you're on bisphosphonate you will be prescribed calcium and vitamin D together. No, so it's something that you do yourself. Okay.
Yeah.
So, okay, so
and there is vitamin D3.
Yeah, vitamin D3. I understand that. So yes. So in the UK, we tend to be conservative with our kind of recommendations about vitamin D. Really high levels of vitamin D could have an adverse effects to health. But we're talking about really high levels. I would tell you that in the US and in Canada, they advocate much higher levels of what we do here in the UK as the bare minimum. Okay. In fact, the guy who made that up is a great advocate of that. So I would say to you that you don't want to go to mega doses, but what you're probably saying doesn't sound like a mega dose to me. However, the government recommendation is for 10 micrograms or 400 IU. We've definitely done studies with higher levels than that, and we didn't see any adverse effects. A couple of them here.
Thanks. The question is on protein, which you've already covered really well. A customer came to me and asked me the question, and I said I'm not qualified to answer it. She's been guided to increase her protein because she's just started weight training because she's potentially at osteoporosis risk, and has been told to increase her protein from 1.5 to 1.8 to 2 grams per day.
I understand, and that's a common question. As I was saying earlier on, I don't see where the data for that is coming, is my answer to the above, right? Okay, but it's often advocated. So that is a very common, similar questions are very common, or questions what I get, but I don't see where the evidence for that is, unless someone can point it to me.
Thank you.
In older adults, in people like your client, in proper, yes, in adults like yours. Might be in bodybuilders, but
yeah, thank you.
They're very different clientele.
I'll see that too. Thank you.
Hello, you mentioned vegan diet, and would you share my concern that there are hordes and hordes and hordes of people turning to vegan diets, which are going to be lower in protein, lower in calcium, and do they realise what they're probably storing up for the future? And can something be done?
What we don't eat is a very personal choice, and people follow different diets for very different reasons. So it's not up to me to tell people what to do or not do. It's up to me to point the evidence of what it is or it isn't, and then it's up to them to make the choice. So I hope you didn't get from my presentation that a vegan diet is a diet that couldn't is an unhealthy diet. If you were very careful with what you're eating, then you could still get calcium from loads of kind of plant-based sources, right? Okay, you quite often get calcium now added in a lot of foods, and and the same goes with protein. You just need to be very savvy, however, about the quantities that you're eating in order to meet the recommendations. So as I said, it's very easy for me to meet my calcium recommendations because I have, I have breakfast cereal with milk and tea with milk and a yogurt, and that's it. That's me, done. But for a vegan, they really need to eat a fair amount of green leafy vegetables and tofu and, supplemented almond milk with calcium in order to achieve what I achieved with a slice of cheese and a small glass of milk. Does that make sense what I'm saying? Yeah.
Okay, I think there's another question. Yeah.
Okay.
So I'm just wondering, I have heard in the past, not just like the way you said caffeine can interfere with the absorption of calcium, but the phosphorus in carbonated drinks can actively remove calcium.
So that's the carbonated stuff rather than the caffeine as well. So yes.
So it's also the carbonation is a problem, but I don't really hear people talking about that.
Again, there's not a lot of evidence on that one effectively. So what probably the evidence is suggesting in the younger kind of population where they actually tend to kind of eat lots of drink lots of fizzy juice, for example, is that they're substituting milky drinks with fizzy juice, and that's probably where most of the harm is coming from, rather than from the consumption of the carbonated juice itself. Okay, but there isn't that many studies that I'm aware of that, you know, they have looked at that one. But there's definitely the replacement of having a glass of milk instead of I'm just going to have a glass of Diet Coke or whatever it might be. Yeah.
When it comes to oxalates, does it have an influence regarding osteoporosis?
Only in the sense that oxalates are present in certain foods like green leafy vegetables. They bind the calcium, and therefore you're not getting all the calcium from your portion of, I don't know, green leafy vegetables as you would hope. So loads of vegetarian and vegan kind of websites would advocate green leafy vegetables as very good sources of calcium. And the answer is yes, they are a very good source of calcium, but not, so the plate has got a lot of calcium, but that the amount of calcium that's in your plate is not necessarily the amount of calcium that your body is going to use by eating that amount of spinach or whatever your green leafy vegetables might be. So it's an indirect kind of effect, if you know what I mean.
At the same time, I was thinking about the inflammatory factors coming from the oxalates, so affecting the osteoporosis.
I don't know of any study that has kind of looked at that into great detail, if I'm being honest. Okay.